Afternoon keynote session now before we break for some more workshop sessions, and I'll tell you a bit more about those before we start. But we're looking now at an area which clearly has come very heavily onto the radar of everybody in local government over the last year or so, looking at health and social care reform. Delighted to have Inderjit Singh, Head of Enterprise Architecture from NHS England, here to talk about ensuring local public services in health and social care are fully integrated.
Brilliant. Thank you. Can everyone hear me okay? Perfect. So thanks first of all for the invitation. I was really keen to come to this event because, as much as we'll probably all appreciate, the need for continuity of care across health and social care services is fundamental. So I was very keen on presenting out to yourselves and ensuring that actually that the social care angle and the local government angle is fully heard on this. In terms of the structure of the presentation, there'll be a short kind of animation first, because I was really keen that this starts off not in the tech, that this actually starts off in terms of what does it mean for me as an individual, what does it mean for me or my parents in terms of continuity of care and the ability to provide care effectively, the kind of opportunities that we have where we are in reality, and then also what we're actually doing about it, and a lot of the work that's going on very much in conjunction with local organisations around progressing this agenda. The other thing to warn you is it is a Prezi, so it's slightly roller coaster-ish as it moves around, but just bear that in mind. So to start off with, I'm just going to actually not talk and just play a short video for you, but I thought it was really compelling in terms of actually telling someone's story about where things are now and also where we want to get to.
Over the next 20 years, the number of over 85s in the UK will more than double, meaning many more of us with multiple long-term health conditions. Our current health and social care system won't cope. Fundamentally, it's the same system as when the NHS was set up, designed to treat episodes of illness one at a time. Already, we're failing to give vulnerable people the care they need, and we're set to run out of money fast. Meet Sam. He's 87 and suffers from emphysema, a disease that makes it hard to breathe, and also has type 2 diabetes and arthritis. Sam was coping pretty well until his wife passed away, but is now lonely and increasingly depressed. Sam frequently visits his GP, but finds it difficult to discuss all his needs in a brief consultation. If Sam can't get hold of his GP in a crisis, he calls for an ambulance. Each time, Sam spends time in A&E, and is often transferred to a ward as well. He sees lots of different healthcare professionals and has to explain his conditions repeatedly. Frustrating. And Sam often has to wait to be assessed by social services before he can go home. The result? A lot of unnecessary time in hospital. And when he gets home, a lack of coordination between his GP and social care often means he doesn't get the support he needs. Eventually, after several hospital visits in just 6 months, it's decided to admit Sam to a care home. But what if Sam's health and social care services were more joined up? Let's imagine one of Sam's carers is given overall responsibility for coordinating his care. For example, Kathy, a district nurse. Kathy meets with Sam, his GP and his social worker. Sam explains that he wants to manage his conditions at home, and together they design a care plan which they can all access online anytime. Sam now gets more visits from Kathy at home, which helps him manage his emphysema and diabetes. On the occasions when he does have a crisis, Sam calls Kathy rather than an ambulance, so goes to hospital less frequently. And even when he is admitted, he's discharged after a quick review of his care plan rather than having to be reassessed. In this scenario, Sam's health and social care is funded from a joint budget, so the team can make smart decisions about how it's spent and call on the help of other social services. For example, as his condition deteriorates, the team decide to fit a seat in Sam's shower, provide him with an oxygen cylinder to ease his breathing, as well as a medication dispenser with a voice prompt to remind him to take his pills. Kathy talks to Sam about his loneliness, and he agrees to weekly trips to the shops with a volunteer from a local befriending charity. So now, Sam doesn't have to be admitted to a care home, instead getting the help he needs in his home. He feels happier, is healthier, and better use has been made of resources within the system. Let's recap on what transformed Sam's care. Put simply, local leaders in the NHS, social services and the voluntary sector created a shared vision of what good integrated care looked like, centred around the needs of people like Sam and their carers. They pooled resources across health and social care, built multi-professional teams and created systems to allow Sam's information to be easily shared. Sound idealistic? Well, this is actually already happening in a few places. Now it's time to make sure it happens everywhere. Let's reimagine how we provide care. Get inspired at kingsfund.org.uk/joinedupcare.
So I'm not that sure about you, but when I first watched that, I found that extremely compelling. Again, nothing to do with the technology, but actually we can all probably individually, unfortunately, relate to it, either ourselves or the people that we care for. And actually what I think it really highlighted was, yes, there's the ambition and the vision around integrated care, but really where are we? But actually more importantly, where is it that we want to get to and where can we get to? And also recognise that there are examples where this is happening within the country. Within that wider context, we recognise that actually there is clearly a burning platform. I'm sure you all recognise, even from a political perspective, this is right on the agenda. The population increase, the wider and greater number of people with long-term conditions, and also those over 80s attending A&E and the increase around that as well. There's clearly the need for care coordination, but importantly, to remove the artificial distinction between health and social care. From a citizen perspective, there is no differentiation. It's a continuity and continuum of care. And I think that's one of the fundamental points that comes out of the work that we're now trying to do at a national level, and in the context of the 5-year forward view, which neatly links into the publication. There was lots, I think, really important around the 5-year forward view. First of all, it was very much a cross-system publication. It was something where all the ALBs across health and social care came together, but it highlighted some fundamentals in terms of the funding situation. It also, at the same time, highlighted, as importantly, new models of care and the way in which health and social care needs to be more effectively integrated. It also, as I'm sure we're all politically aware, highlighted that there needs to be some tangible and firm decisions done from a political perspective in terms of how this funding is going to be resolved. What it does highlight, and I think these are some important statistics, is actually where we could potentially get to if we don't look to start addressing this situation. So really, what's our aspiration? What's the question? What's our vision in terms of what we're trying to achieve? Well, in effect, being able to provide that high quality care, but also at the same time delivering greater value for money. And those two things can happen, and there's fundamentally a role for technology embedded as part of user journeys and citizen pathways to be able to do that more effectively. And that's where, in effect, the strong emphasis around health and social care integration comes about. The reason why I very much started off with Sam's story was if you just start off with we need health and social care integration, that's a technical discussion. What you need to really start off with is what does it actually mean for me as a citizen? What does it mean for me as an individual, of which there is a fundamental role around health and social care integration. And this again highlights the fact that this needs to be done in terms of the outcomes that we're trying to achieve for the citizen and the experience improvement we're trying to achieve for the citizen through the use of technology. And evidently, as we heard this morning already, there are significant savings that can be made through moving from face-to-face to digital channels, but actually as importantly are the outcomes and the improvement of the patient and the citizen experience through that, and probably even more so. So following the 5-year forward view, how many of you are aware of the Personalised Health and Care 2020 document that was published? Right, okay, so that's interesting in itself. So the Personalised Health and Care 2020 document was a cross-system document across both healthcare and social care organisations. LGA, there's a whole stream of work for local government being led up as part of this. I would definitely urge all those that haven't read it to read it. It's basically the technology strategy that underpins the 5-year forward view. And within that, it defines a number of commitments that are going to be achieved, a number of sets of work areas that will be focused upon over the next few years. Not surprisingly, health and social care integration is a fundamental building block as part of that, which is kind of where my role fits in. But also, there's a whole area around how we make more convenient and accessible channels for citizens to be able to interact with their health and social care services. From the Personalised Health and Care 2020, what that's enabled us to do is, in effect, have a number of key work areas where we have complete system-wide support and focus. And when I mean system-wide, I mean in terms of CQC, Monitor, LGA, NHS England, Department of Health and so forth, with the entire intention that all the various levers and requirements and incentives start getting much more aligned. I think we all recognise that it's quite fragmented at the moment. So as part of that, what's some of the key things that the Personalised Health and Care 2020 document talk about? For me as an individual, better access to my information, greater involvement and control in my care, the means in which I can manage my own care more appropriately. And I'm sure the one we've heard many times, to be able to tell my story only once and not have to repeat it every time I interact with a different part of the health and care system. So as you can see, in terms of outcomes, there's a clear need and signal around how we start moving and making greater use of digital channels, but importantly, not within a technical context, but actually within a patient experience context. And what's the ask to the overall health and care system? Evidently, with the funding situation highlighted through the 5-year forward at the same time, how we do this in terms of best value for money. How we make the most out of the technology and achieve technology efficiencies. There's kind of been this situation where we swung from the national programme that just said thou shalt, and there'll be one big monolithic system that will sort everything out, right through to 1,000 flowers that are blooming in different directions. There is a natural need to meet somewhere in the middle. How do we make the most out of our national as well as our local assets? And fundamentally, as part of that, how do we deliver joined up care? And so these are the opportunities that we've got, and I'm sure I won't go through each of them, but they'll resonate with as you go through in terms of making a much more active citizen, a much more empowered citizen, and a citizen that can able to use the information being shared across the health and social care system. But while that's the vision and that's the ambition, we have the reality. Social care workers may spend 20% of their time with service users. Nurses manually filling in 80-page continuing health forms. So while there is a vision around a more effective health and care system, and frankly the need to have one, we recognise a situation where, while on one hand we've got groovy apps on our smartphone, on the other hand we've still got 80-page documents around continuing care that our care professionals need to fill out. And the situation where, as a patient or a citizen of social care, I can't easily access information about me held by the health and social care system. And from a technology perspective, we have national infrastructure. Some of it works really well, some of it doesn't. Some of it actually potentially causes more blockers. We have, as I said, the situation where I have my personal health record on my phone, I have my health kit. At the same time, the discharge letter that's going from the hospital back to my GP is used second-class post. So we have this massive variation in terms of actually how technology is being used and its effective use, which again isn't necessarily a technical issue, but is much more how do we start embedding this as part of health and care practice. And this situation where we have the need for integration and information sharing, but actually in a way, because we've got 1,000 flowers blooming, there are so many ways that we potentially share information that actually we may end up creating more silos or more complexity within that. So, what are we going to do about it? So I've highlighted the vision, I've highlighted where we are in reality, but I was keen to take you through actually some of the tangible work that's going on, very much being locally led, but in conjunction with the national organisations. First of all, my kind of personal reflection is interoperability or health and social care integration is kind of one of those things akin to world peace. You know, we all want it, but we're not quite sure how we want to get it. And actually what we need to start doing is breaking it down in terms of tangibles And actually, where is it that we want to start? Where's that focus? We can't all try and do everything at the same time, so what are some of the key priorities? So in terms of some of the key areas that we've been focusing upon and work with local organisations upon, probably sound fairly simple, but actually some of the key building blocks. The use of a consistent identifier for a patient as they're going across a care journey, across health and social care, whether I'm a patient or a service user. So the use of the NHS number. And there's as much a reflection that health doesn't use it that well as social care. Actually, in a recent number of surveys that we've been working with the LGA upon, actually in a way some of the social care vendors are more up to speed with the use of the NHS number than some of our health colleagues. So what we've been doing there is not necessarily just saying use the NHS number or here's the standard, go and use it, but actually taking a much more holistic and coherent approach that says, right, what are the levers, what are the incentives, so the Better Care Fund, the Care Act, what needs to go within standard contracts, what needs to be as part of commissioning guidance, systems readiness, so what supplier systems are there that can enable you to get NHS number, and also in terms of more effective guidance and more supplier offerings, so spine mini services, for example, that ambulances are using and other care authorities are using as well. So taking a much more holistic approach that isn't just publish a standard, but much more a lining up the levers and the incentives, the market readiness, the local understanding as to how it can work and how it can be accessed. In addition to that, and one of the more recent priorities is around discharges. So as I said previously, while we all have 2 or 3 smartphones and loads of apps, at the same time our discharge letter is usually sent through the post, and by the time I reach the GP they haven't got it yet. So actually one of the key priorities around the information sharing agenda is to start getting off paper for discharges. So for health organisations, by October, the standard contract stipulates that you won't be able to share discharges coming out of hospital to GPs on paper anymore. It has to be done electronic. And we're working with social care organisations because recognising that actually there are different levels of maturity within social care around how do we start moving to more effective sharing of discharge information. The example around the PRSP is more of a clinical example than it is a social care example, but I think it's a relevant one. And this is actually where if you ask someone what a discharge letter contains or it looks like, everyone's got a different opinion, everyone's got a different structure, different content. And actually, until you start having some consistency in actually what you want to share as part of a discharge, it means that actually some more of that more intelligent workflow that you can do on top of it becomes very difficult. The PRSB is a professional records body that now also has social care representation that is looking to define, from a professional perspective, so not a technical perspective, a number of consistent key clinical headings around key transfers of care, be it discharges, referrals, and so forth. And Keith Strawn, who's one of my colleagues, actually works at the HSCIC, sits on that board representing social care. And there is a number of pieces of work now going on around social care discharges and social care transfers of care that are looking to start defining more consistent clinical headings. So this is my facts analogy, where the intention is at some point we will be able to come to the point where we actually won't be using fax. There is this slight analogy off the cuff where there are a number of fax companies overseas who would like to stop building faxes and providing faxes, but actually it's the NHS, the health and care system, that keeps on buying them. So at some point we will get to the point of a bonfire of faxes. In addition, what we're then doing is very much working with local organisations. So I think that point I said at the beginning around it's not national, it's not let a thousand flowers bloom, but actually something about working collectively and collaborating is that we're doing a lot of work now with the integration pioneers, really to understand actually what are the key issues, what are the key requirements, what are the key common pieces of information they want to share, what are the key blockers. And so very much working with the integration pioneers and going through those to be able to start creating a community, but also to be able to provide some practical tools and guidance to be able to help them deliver their local health and social care agenda. So within that, actually, what are some of the key standards that we need to start pushing for interoperability information sharing? How do we break down the myths? We don't need another information sharing agreement or another IG template. Actually, what we need is in these kind of key cases or key scenarios, this is how local organisations have been able to resolve this. So that's where a lot of the practical guidance is being developed based upon actually what's already being done out there across the health and care system. And then also, as importantly, articulating the direction of travel. What's the future role around the summary care record, for example? How are we looking to link the shared care records that are now evolving, the Hampshire Health Record, the Leeds Care Record, the Bristol Care Record? How do we avoid the situation where in 5 years' time we've actually created more silos of information than we have to start off with? And this is where one of the key bits of guidance and policy that we did produce last year was the Open API policy that said, actually now, and it's within the standard contract for health providers as well, is if we're going to start on the interoperability information sharing agenda, we need to start developing procuring systems that have open APIs, so at least I can start getting access to the information. And what we purposely did was write the policy so that people actually understand what it means, because the term can mean anything to anyone, but then purposely put a set of standard OBS requirements at the back of it so that anyone could lift it off and put it as part of their local procurements. It's also one of the conditions for the Better Care Fund as well, around open APIs. We recognise that the market isn't there yet. We recognise that the market's only starting that. But the whole point is if we make a more set of intelligent customers to our suppliers, then that'll actually help move the market in terms of getting those suppliers to start opening up their systems. And in addition to this, as I said, in terms of the work that we're doing around information sharing, it's very much being locally led. What is it that local organisations are telling us that isn't working? What guidance, what support do they need? But also recognising that we have this situation where there are a number of leading lights that are out there. So kind of a situation where we have a number of integration pioneers, not all who are pioneering, and a number of pioneers who aren't called pioneers. So we're in effect creating an overall cohort of where there is the best practice out there. And then finally, in addition to the interoperability bit, because it came up so much today, evidently if you start moving beyond just integrated records between health and social care, very much on how we start centering these around the patient and the role of personal health records as in effect the ability of the place for a citizen to be able to not only enter their information but also be able to pull in information from their care and health system. Evidently as part of it there is a massive need to actually know who's on the other end of that digital transaction. So at the moment a lot of our interaction is face-to-face, but as soon as this massive ambition around moving digital people start getting on the bandwagon of, there then becomes the issue around actually how do I know who's on the other end of it. So coming back to what was talked about this morning, I also lead up the national work around citizen identity under the National Information Board, and as part of that there are a number of alpha projects that we've got running, because in my view we need to get off the theory, but also we need to not focus on the tech but actually understand what user perception is around this. So there's already an alpha project going on in Liverpool, run by Liverpool CCG across themselves and their social care colleagues, where they've already built the verified platform locally, and they're now doing a bunch of user testing within that as well, and looking to go to a private beta with the Cabinet Office in July. However, my view is that Verify is really useful, but in terms of choice, there will be people who either can't use Verify because they don't have the history, a passport or driver's license or so forth. There will also be those people that don't wish to use it because they don't want to associate going to Experian with accessing my health and care information. At the same time, we've had the Patient Online initiative, which has all been about enabling patients to be able to access their GP records and book appointments and so forth. What we did last year was a lot of work with the Cabinet Office about how health and care have got a slight special nature to them in the fact that I already have a long existing relationship with a professional. Either my GP's seen me 10 times in the last 10 weeks, or I've been as part of their practice for the last 20 years, for example. So what we got agreement with last year was that actually you could use your professional relationship as another way of vouching for someone's identity. And as a result, with Patient Online, there's now about 5 million people who have been registered for that. And we're running another alpha project in Hampshire where you use the fact that you've been vouched by your GP to then be able to access any other health and care setting. So again, it means that you only get vouched once, but actually you can then access other information. Interesting, that's not a technical question at all. That's all about clinical trust and information governance. but it seems like something that we need to be looking to investigate. So in terms of the identity strategy, it basically goes along the lines of there will be a common set of identity components that you need, but there will be different ways in which you could choose to verify yourself, either using gov.uk Verify or potentially using a professional relationship. And the other thing we're looking at is there's over 1 million people who are NHS employees who've already been verified to get a smart card for work anyway. So why would I not use that as a verification for me as a citizen? So if people are interested in terms of joining that initiative, more than happy to have a conversation. We've got Liverpool lined up around the gov.uk piece. We've got Hampshire Health Record lined up as an alpha around trusting a vouching by a GP. And John Jackson, who I think is going to be here later on, is already looking to line up an alpha from a social care perspective, because I think that's a really fundamental priority area to look at. More than happy to take questions. Thank you.
Thank you. Okay, we've got about 5 minutes before we have to break for the workshop session. So if anybody has got any questions for Inderjit, now is an opportunity. One down in front. Just wait for the mic, Mark.
Thanks, Mark Say, UK Authority. I'm interested where you were talking about using GPs as a possible source of vouching for an identification. I wonder, will there be any kind of time frame on that in terms of how long they would have had to know that person?
Can you hear me all right? Sorry. So what was really fascinating when we did the work last year was we got agreement from the Cabinet Office to say, yes, you can trust a professional vouch. We then asked the GP community to say, well, what do you define by professional vouch? And in a good way, they said, actually, you've got to leave that to professional discretion, because we artificially said, is it a certain amount of time? Is it a certain amount of interactions? Now, actually, if I've got, unfortunately, cancer and I'm seeing my professional every week, then they're going to know who I am, versus, say, for example, if I've been registered at the practice for the last 20 years, but I go in every once a year. So actually, it's very much based upon clinical discretion. The important thing to note is this is very much an exploratory stage. So we're looking to understand how this could potentially be done, but very much this is us working with the professionals to help us understand this potential approach. And it may well not be applicable, but we don't know that at this stage. So that's where we're very keen, and we're working with professional colleagues to be able to get their insight and their direction as to how this potentially could work.
Any more questions? One over there, John.
Thanks, yeah.
See you later.
A couple of observations that I kind of like your reflections on, if you like. So the first is that while essential care record's important and significant, actually what's more important is a common care pathway. So actually, how does a workflow, how does a business process flow between agencies is the central thing. Having some care information that's central is part of that, but actually doesn't deliver that. So I'm just interested in your view of where the vision goes into that area, which takes me to the second observation, which is that the care economy isn't just about health and social care. It's so much more about third sector, health, police even. So the police are saying to me in Solihull, every time I put up a helicopter to find someone who has gone missing because of dementia, I need some information about that patient's dementia information. So police are part of care and protection, public health are as well. So it's a much bigger economy of care and protection, and the care record focus seems to be too much about the data, not enough about the process, and not enough about the agencies that are involved. And I wonder if you have a sort of view of where that big picture goes.
So I think, so I entirely agree. So the health and I probably, when I use social care, was shortcutting to mean social care and voluntary sector and additional agencies and so forth, because fundamentally me as a citizen doesn't see any distinction between the group. I think at the same time we need to be realistic as to where we are now, and even with the pioneers, they're at the start of the journey around how much health and social care integration there is. So I think the ambition is entirely where we need to be going, and as you said, I think in terms of the point around care pathways and clinical workflow, evidently, and that's why I started off purposely with the user journey and then went to the technology. There is a concern that if you talk interoperability, you're talking tech right from the start. Evidently, clinical workflow needs to have the underpinning set of care records underneath it. At the same time, clinical workflow needs to be led by that local service. So do I think that there is necessarily a set of standard workflows? That's probably more a question to our professional colleagues than it is necessarily to the technologists.
It has to be driven by
Of course it does, of course it does. But what we need to ensure is that we put in the enablers in parallel to that, so we don't get the situation where, well, we want this, but all the techies are saying that we can't have it.
Okay, we've got time just for one more question at the front here.
Thanks. It's William Heath of Midex Kick. Indy, you talk about personal involvement, personal control on the personal health record. I wonder what range of data do you think would really help this process if it were controlled and shared by the individual? I mean, because no one's ever called a person a silo, have they? The more you give it to the person, perhaps the more you get rid of your silo problems.
So I think there's a fundamental need for me as a citizen. So I kind of give the analogy of me as a citizen being able to A, get my medication from my care records, B, be able to add in my own medication information, and C, to be able to get information syndicated from the likes of Choices that explains what my medications are. You know, so it's about being able to bring together multiple sources of information and me actively be able to contribute to that as well.
Okay, I think that's all we've got time for on the questions. With the other ones, the next session's coming up. If you could just show once more your appreciation for Inderjit Singh, that would be very much appreciated. Thank you. Thank you.